Hello and welcome everyone. Okay, yes, that's right. My background is a little bit different today. I will be asking you a little bit about that in a second. But welcome. Thank you so much. I can see a lot of you are here on time. It's really, real pleasure to see you. I've been looking forward to this session for quite some time now. As you can see on your screen, it is called the GLP-1 Aftershock Effects. And the subtitle, What 100 plus obesity brand stakeholders say is changing and where pharma marketing goes next. Well, we will reveal all in just a second, but there will be a couple of insights to share that you may or may not be aware of on this webinar, and I'm super excited. So my name is Paul Sims. I'm calling you today from my vacation. I'm really pleased to host today's webinar. Now, most of you who've been on my webinars before, you know the drill already. Get that chat window out and say hello, please. I want to know where you are, who you are, where you're calling from, and perhaps for an extra special gold star today, maybe you can even have a guess at where you think I am at the moment. And I can assure you it is not my own home. Okay, so we've got about 300 people signed up. And I think that what I want to really articulate from the off is that this is today about GLP-1s, but this is, of course, an area that is relevant to everyone. And the reason for that is because in many ways it has kind of upturned so much of what we have held firm in our industry for quite some time now. The fact that patient demand is so strong has almost reordered the way in which we do things. So GLP-1s, and I'm many of you working today will work in obesity, but not all of you will. And GLP-1s aren't just a hot moment of some kind. They are exposing something a little bit bigger. They are showing us what can happen when a pharma category kind of starts behaving a little differently, a little out of order. Normally, we're used to building the evidence, then educating HCPs, then securing access, then generating demand, finally getting that support uptake. But now it's scrambled. Demand has arrived early, loudly, and from multiple directions: patients, culture, private pay, digital clinics, employers, social conversation. The result is a market where awareness is no longer the scarce item or asset. The harder questions are, can the demand be qualified, accessed, afforded, trusted, and of course, sustained? So that's what we mean when we say aftershock effects. That's the exploration that we want to do today. We want to see what pressure that might put on the old commercial funnel and what second order, third order effects it's going to have perhaps on other parts of the industry. What can we learn from this? What can we take into other parts of our industry, even if the demand isn't as strong? So the good news is that it's once again not just me who's going to be hosting today's session. I also would like to introduce Christine and Sean. So Christine, on the left, she is the medical director at Edgewise Therapeutics. She is passionate about how obesity care is indeed reshaping commercial strategy, but also earlier than that, R&D clinical strategy. Patient demand, access to AI, marketing engagement, customer engagement, new routes to market. She's very much driven by curiosity as well as being a real innovator. She's got a track record of turning insight into action, of building meaningful customer experiences and navigating change. Super, super excited that you could join us, Christine, because we know that you have serious experience in this area in your previous role. Sean is a partner at the newly branded, drumroll please, BGBx Consulting, and there he is helping healthcare organizations to unlock growth. And doing that not through just the normal agency work that you might be aware is BGB's legacy for sure, but through pragmatic strategy work and through data-driven insights, a glimpse of which you're going to get very soon. He, by the way, has experience in pharma, biotech, medtech, health IT, and digital health, so perfect for this conversation. Passionate, of course, about transforming complex challenges, and this certainly is one of those, into actionable opportunities. And he's got lots of experience across different consulting advisory roles, and of course, creating a more results-focused landscape. So I am super happy that we have both of these guys here with us today. Now, you might recall that when you signed up for today's webinar, you answered a couple of questions on the way in. Do you remember that? So question one, as demand for obesity treatments rise, what is actually driving your brand strategy today? And you can see the pie chart under question. Let's see what the different segments are. There's clearly a winner on that 32% item. Patient demand is becoming a primary driver of brand strategy. Okay, remember I said that not everybody signing up for this webinar is in obesity. So that is super interesting because of course it means that that patient demand is leaking over and being a driver elsewhere as well. 20% of people said access and affordability becoming the real commercial battleground. It is no longer good enough simply to be a marketer, clearly. Differentiation is moving from claims to experience and support, getting nearly 16%. 15% HCP engagement is being rebuilt around more informed patients. And then finally, the last two, the basics still matter most, less than 10%. AI and data, of course, changing how teams sense and respond to the market, the lowest amount. Interesting. Okay. Question two was, where do you feel you're least prepared as this category evolves? Where are you least prepared? Okay. Slightly more of a distribution here. We've got three clear winners, I would say. 28%. Differentiating in a crowded category without overstretching claims. I often describe differentiation as a lost art in our industry, as we have really strove for right time, right place, right message. And of course, that is not as much about differentiation as traditional marketing was have us say. So I think it's very interesting that that's come to the fore in this location. Responding to patient-led demand, for example, with direct-to-consumer or patient activation models. I don't think that's a big surprise there. 18% new access routes such as employer digital clinics and partnerships. Yes, obviously very key in this area. 12% proving ROI. And then the rest, the best of the rest, omnichannel and customer engagement operations insufficient. AI again appearing, and MLR, hooray, everyone's favorite topic at 5.6%. Okay, marvelous. Oh, there are even smaller categories. I missed these ones. Building enough internal confidence and 1.4%. Nothing. We are fully prepared. Well, you're in the right place, I guess. It's time to get prepared. So I'm going to have a quick look at the chat window to see who's guessed where I am on vacation as I speak to you today. Yeah. Oh, south of France. You're not far off. You're not far off, people. That's some pretty good, pretty accurate. Are you guys following me? I've never had a stalker before. Perhaps it's time. Well, I suggest we better get on with the webinar, don't you? Okay. So first things first, I'm going to actually get another poll question going, a brand new one. So if you look at your screen right now, you'll see a new question launching. And I'm going to get rid of my slides and ask our wonderful panelists to turn their cameras on and show their wonderful faces. So the question you see on your screen, it's a two-parter, reality check. So two multiple choice questions. I'll let you take your time to have a read of those, but they're really about what we see in the room today, just to kick things off with. Okay, guys. Christine and Sean, what a pleasure to have you with us. Thank you so much for being patient there. I really want to start with just getting your core thoughts on whether or not we really are breaking the old commercial assumptions. From you guys, from where you sit, you've been more hands-on with this than I have. Have GLP-1s changed things permanently? Do you think that there's a high chance of that? Do you think it's more than just a clinical and commercial story, the same ones that we're used to? And, I'm really keen to hear where you think the main battlegrounds of the future will be when I get my voice back. I think it's time for you guys to start talking. Someone's telling me to shut up. Christine, Sean, who would like to go first on those questions?
I can jump in first, Sean.
Jump in,
I would say putting on my medical affairs cap, and I've particularly worked in smaller, earlier stage biotechs, more involved in clinical development. I would say from my perspective, the use of GLP-1s increasing significantly over time really changes how we think about earlier stages in clinical development, having to accommodate study design decisions around what we perceive the utilization to be as a start.
Okay, thank you for that. Sure.
Yeah, I mean, big question you asked, but I think GLP-1s are here to stay. You know, to your question around future battlegrounds, I think there's a lot still to happen. You know, right now there's kind of two big manufacturers that are duking it out, but there's a lot more entrants that are expected to come. And so I think it's gonna be really interesting to see, you know, as new products and new options come to market, how share evolves. So I think there's going to be lots of different battlegrounds depending on the product, whether it's oral versus injectables, cash pay versus reimbursed, or even getting into specific subpopulations. You know, if you have preferred options for certain comorbidities of obesity, so maybe be winner in sleep apnea if a patient has obesity plus sleep apnea, or if there's more preference for you know, for one option for MASH. I don't think the market has gotten to that point quite yet, even though there's some differences in label today, but I could see those being some of the future battlegrounds that we see evolve.
Okay. I'm going to end the poll in a couple of minutes, so please make sure you've answered that. I can see just over half of you have so far, so please answer that if you haven't already. So guys, you gave quite succinct answers to my multifaceted question. You're clearly more concise than I am. What do you think that the key battleground is? You're a new medicine launching into this space right now. How are you going to win? Let's just imagine that your clinical superiority is not sufficient to bring you enough differentiation on that front. Tell us a bit more about at least the key considerations that you're going to have as you move into this market that might be different from perhaps how things have been in the past.
Yeah, I'm happy to jump in with some initial
Sure.
thoughts. For me, like a lot of it goes back to unmet needs and what patients are asking for and what clinicians are looking for in prescribing a treatment. And so I think in this market, like top of mind for everyone is cost and access. And so I think that is a future battleground. If you're a new entrant and you don't expect to have, you know, better efficacy or depth of weight loss than Zepbound, you know, that's one area to go after is price. And I think you've seen that a little bit with some of the oral options positioning that way. But there's a much longer list of kind of unmet needs that could be addressed, I think, from both the data generation standpoint and for the product profile itself. So things like the depth of someone's weight loss over time, so not reaching that plateau that you might have 12 to 18 months after treatment and having kind of continued improvement in weight loss over time. There could be the quality of your weight loss, where you know you're preferentially targeting fat loss as opposed to you know having both a combination of muscle loss or lean muscle loss in addition to fat loss, which I think in some patients can be up to you know 40% of their weight loss can be from lean muscle loss, which I don't think is the ultimate goal for most people. I think tolerability is a big area that I think manufacturers are focusing on, especially in combination with their overall efficacy. I know there's a lot of investments in improvements in administration, so less frequent dosing for injectables or obviously oral alternatives. And then, you know, comorbidity benefits, I think, are a big area as well. So those are some of my initial thoughts, I guess, on where you can see differentiation and, you know, new focus for entrants.
So Sean, just sticking with you a second longer, I was actually a little surprised to hear you say cost so early. Do you think that this market is already at that mature level where cost is, you know, that's normally what we see in a market with lots of, you know, similarity, almost commodity-like players. Do you really think that cost is a huge driver at this point, and why is that?
Yeah, I mean, I think it's because patients have so much of a say in what treatment they're choosing in a lot of cases. You know, there's kind of mixed access right now and coverage for a lot of patients. So I think because of that, a lot of providers are deferring a little bit more to patient choice and taking an approach of saying, here are the options, let me lay them out for you, as opposed to being more directive and saying this is the best one, especially given there are a lot of patients that are taking the self-pay route. I don't, you know, it's hard to get an exact number on what that is from a self-pay standpoint, but you know, I think it could be somewhere in the range of 20 to 30% are paying today for self-pay for branded options. And so, I think that when that's the case, like cost sensitivity is a big issue, and it not only plays into which one you're choosing initially, but then how long you also stay on treatment. And as a category, adherence has been a challenge for GLP-1s with patients not necessarily persisting for long periods of time in a lot of cases. And I think a lot of that has to do with access, it has to do with cost. And so I'd expect that to still be the case, even though there's only, two big players in the US today. They've already in the past, year and a half or 2 years dropped pricing pretty significantly as they've pursued and invested in self-pay options. So I'd expect that to still be, an area of focus. And tiering some of the options that are available today, because you see that already with orals being a little bit cheaper than what you can get from a self-pay standpoint than injectables. And then even within the injectables, there's this range that's being set up for the early starter doses being cheaper to incentivize that initial adoption, and then having some of the higher doses increase in price. But I think there's just a lot of different levers that can be pulled from that standpoint, even beyond where they are today.
And Sean, I think
yeah, please go for it, Kristen.
Yeah, I think Sean brings up a really good point. It goes back to the second poll question around being prepared for differentiation. I think we could all agree those are key areas that Sean mentioned for differentiation. The question is, if you have a product that you're trying to launch, why don't you have the evidence, that you want to need to sort of differentiate on the market? And I will say this, probably ad nauseum during this webinar, I'm a huge advocate of involving commercial and medical earlier for that reason. Part of that journey is creating the evidence earlier to have the data to differentiate across some of those different regions. Me putting my medical cap on, I would find it difficult in commercial to try to differentiate if the data essentially is, non-inferior or similar. And so those are discussions we have on the clinical development side. And we try to pull medical and commercial in earlier to have those discussions earlier to make sure that you're getting the data you need to be able to differentiate on the market as well.
And do you think, Christine, given what you've just said, that cost will be such a defining measure going forward? Sean kind of hinted that it's been very impactful today because of patient input, but do you really think that that is going to, or do you believe that the clinical differentiation and all that wonderful work that medical and commercial will be doing to get positioning better right will pay off?
It's challenging. Of course, I'd love to sit here and say evidence will always win. We can only do so much, but what I know also in my experience as a pharmacist is really it comes down to access and cost. We can put together the best data in the world, but if a patient cannot afford a medication or get access, it's all for naught. And so that will continue to be a challenge, but I agree with what Sean said earlier. I think they are here to stay. And it's an interesting framework to work within, with the patient demand being so high. But yes, I believe cost will continue to be a factor.
And do you think that that makes this still an attractive? I watched an interview with David Ricks last week. He was saying that anyone looking at entering the GLP-1 space right now is crazy. The horse has already bolted, and we as a company are focused on the next thing. We are not focused on GLP-1s as our primary investment area anymore. So do you think that with cost being such a factor, this is, and given what people like David Ricks just said, this is still an area that is going to attract as much investment as it you might think it would, given the incredible results we're seeing? Is it viable, basically?
I think it can. I think there's still a significant portion of the market out there that is untapped for obesity alone. And if you look at what's happening on the clinical development side, looking at a multitude of indications across the board, some of them obesity related, like HFpEF with obesity, which I work in. If you look at what Eli Lilly did with their recent basket trial, looking at multiple indications for a single product, is quite elegant in terms of trying to achieve different indications for a particular product. So I guess my answer is no. I think it probably depends, but if you look at what's happening and how they are trying to branch out across multiple indications, very similar to what the SGLT2 inhibitors did early on, I think that's very possible they can continue to grow.
Okay. So guys, you could, go on, Sean, please.
I was going to add to that. I mean, the thing that's always shocking to me is to kind of look at the sales data for GLP-1s and realize that it's still very early and from a penetration standpoint, and there's lots of runway to go. I think like when I looked it up, there, Novo and Lilly combined reported about over 75 billion US in sales last year. And from an opportunity standpoint, at least in the US, I have a very US focused lens. There's over 130 million patients that are drug eligible with obesity or overweight with a comorbidity, but not anywhere close to that in terms of using GLP-1s. And so I don't, obviously there's hundreds of trials in the space, and it's highly competitive and getting a lot of investment, and maybe realistic to say that not everyone is going to be a winner who's investing in this space today. But I do think when you look at the magnitude of the numbers, like you don't have to get to a huge market share in order to have a really meaningful revenue opportunity in this space. And so I think to Christine's point, like if you're, there are niche opportunities, especially if you're taking more of a targeted approach with certain subpopulations or going after certain comorbidities, like that, those are all, I think, viable pathways for future entrants. And I wouldn't expect it to just be, only two players given the amount of investment and clinical development in the space today.
Okay, well, time will tell, but I wouldn't be surprised if you were not correct. I'm going to ask you to share some data in a moment, Sean, but before that, please have a look at the data that you guys have already answered in terms of this poll. You can see that patient demand got the top item in terms of where we think the most pressure is today, with 26% access and affordability, 23% differentiation, which obviously just came up in our conversation at 16. For me, the most surprising one, well, not surprising, most notable one, I guess, is the fact that 0% of people said nothing. So the model is clearly under pressure, according to everybody that is listening and watching today. How much is patient demand influencing brand decisions in your work today? And I ask this question across all therapies, no matter where people are dialing in from today. And a core driver said just under a quarter. The most was a third major influence alongside HCP priorities. And I believe that that has grown. I reckon if I asked that question 5 years ago, it would have been a pretty different result. I also think that if I ask that question 5 years from now, it will probably increase even further. Would you agree with me on that, Christine, Sean? Nodding heads. I'll take that.
I'm going to say yes.
Yes, agreed.
Okay, amazing. Sean, would you mind sharing your slides, as I believe you have some insights and work that you at BGBx have done, and you are kindly willing to share with us?
Yes, let me pull it up.
There we go.
Okay, great. So
you may see, by the way, you may see another poll question arrive in a moment, but Sean, over to you.
Okay, great. So yeah, we wanted to share a 2020 survey BGBx did last year. This was with brand leads and marketers across the top 8 therapeutic areas in pharma. And goal of the survey was to kind of understand their needs and challenges and how it differed across therapeutic areas. So the total sample for this survey was 800 responses, but this is a cut of the data that's focused just on obesity marketers. So you can see there's about 100 respondents in this data. And it's a mix of directors, senior directors, VPs, some C-level, mostly folks that are from an agency selection standpoint kind of involved in that decision. And then you can see on the right-hand side, there's a mix of different company sizes, from smaller biotechs to more established pharma. So some of the questions that we asked as part of the survey that we wanted to share was kind of at a high level, what is keeping obesity marketers up at night? And you can see on the left side, we have the top 3 issues that respondents shared. Everyone's favorite topic was number 1, regulatory compliance and MLR processes. But that is just a big challenge today in the obesity space. Number 2 is managing budget and resource constraints. And then 3, very close, was speed to market. So all very close in terms of their percentages for what marketers were sharing were their top issues keeping them up at night. And in terms of, on the right side, critical goals for them to achieve, about half said enhancing their brand positioning and competitive differentiation. Next was successfully launching a new indication or product extension. And then after that is improving brand awareness among both HCPs and patients. And so I think this just speaks to some of the challenges that marketers are facing in speed, as well as demonstrating differentiation in entering the space. On the next slide, just wanted to talk about or share some of the data that we also asked related to the top emerging trends from the perspective of obesity marketers. And so the first one on the left is kind of an obvious choice, that GLP-1s within obesity marketing are the top trend. But I think within that, there's this component of how can I compete with the advancement of the class into new mechanisms. And then the second key trend was patients' willingness to pay out of pocket. So some of the things that we talked about already in terms of cost sensitivity, consumers maybe going outside of typical routes of only adopting if they have coverage within their policy, but many consumers taking the self-pay route. And then third, being one thing we haven't talked about quite yet, which is weight stigma reduction, which I think is also an important topic, both for consumers and then also for patients, and also for HCPs treating patients today. And marketers mentioned, in particular related to that, inclusive messaging being important when it comes to weight stigma reduction. So this was just some quick data that we wanted to share from this survey, and help spark the conversation.
Thank you, Sean. Appreciate you sharing those things. Were you surprised, as I was, to see compliance and MLR hit the top section there? And I'm just curious as to any reason why you think that might be. I mean, apart from the fact it's persistent across every therapy area, of course.
Yeah, I mean, on the one hand, you could say it's the easy scapegoat, right? And it's probably a challenge for a lot of marketers today in terms of feeling a little bit handcuffed in terms of their abilities to promote. But I think it also maybe speaks to just how important it is to reach consumers with the right message, and being direct to consumer being such an important part of obesity treatment, both generating interest, generating awareness, patients feeling like they trust the treatments that they're going to adopt. I think those are all really important. And like we talked about earlier, differentiation is not easy. Just given the dynamics today, the bar has been set pretty high, and so I think looking for creative ways to do that is going to be a challenge.
So, I mean, my thesis, and I'm not entirely sure whether you said this or not, is that simply because the need for differentiation is strong and the model is being innovated, it just requires more change, and more change requires more compliance hurdles. Simple as that. Is that a reasonable thesis, or have I oversimplified?
No, I think that's a fair characterization.
Okay. Christine, would love to hear your thoughts on this. Any reaction to Sean's data, and also your thoughts on what the primary challenges we need to overcome to be successful are?
No surprises with respect to MLR being in medical. It is a necessary thing that we all have to go through, and we have to do it. I would say, as these additional indications, if they are approved and some of these options do come to market for these various indications, there will be an increased need for education across the board, right, in terms of these new indications. And so we're talking about obesity today. And so I don't know that challenge will go away. To Sean's points, the differentiation and the communication will have to continue. MLR will continue to be a part of the process that we will have to work through. But point being, education, I believe, and would encourage you all to still keep that in mind, will still continue to be important throughout this process.
Okay, thank you. I'm ending the current poll and trying to share the results of that with you. Can you see those? I hope you can. Broken funnel. How would you describe the current obesity funnel? And you can see I gave a range of options there that sort of almost probably again over summarize the funnel. But you can see that a third of people said that direct patient search and self-education are core components of social cultural media driven awareness, really similar to that at 21%. And then I asked, where's the biggest break? And demand is blocked by access or eligibility, not quite compliance, but obviously we've spoken to those themes overall, and we even talked about, of course, price being a huge factor in that. Can you guys offer any further advice beyond clinical differentiation? Is there anything else that you guys can think of that we need to be cognizant of, or at least we need to be better at when it comes to positioning and general market strategy when it comes to this? Is there anything that GLP-1s are teaching us that we can apply across other therapies in this space? And I'm very happy with awkward silences, by the way, so I'll just sit.
I can jump in to break that. I think one thing to keep in mind, at least something that I think about often, is fundamentally this class is changing standard of care across today, across obesity and across different indications. So they will, I think, be here to stay. And it's important to keep that in mind as we think about, yes, I know we're trying to diverge from differentiation, but from my perspective, again, from a clinical development standpoint, they are very effective, not only for obesity, but potentially for other indications as well. And think about how to navigate clinical trial development, generating evidence with a class of drugs that many, many patients are taking that are effective and in essence raises the bar, right, for other medications trying to come through the funnel and through the pipeline for various indications.
Yeah, and I think, I mean, just to add to that, I completely agree. I think there's also this element of like this category creating or accelerating the trend of patients having more ownership for their healthcare decisions. And I think saw some of the responses in the poll kind of alluded to that, with patients doing more independent research and the influencers of their decisions. I even think there's a lot of influencers that are driving awareness and adoption generally outside of healthcare through podcasts and social media that are kind of changing the dynamics a little bit. I think there may be some spillover into other categories where patients are more likely to maybe engage with choosing or learning more about different options. And so having more resources for patients to do that, to own their decisions, to be able to be kind of a little bit more active and guiding care discussions with their providers in a way that maybe doesn't always happen in other categories. So I could see that being an area that continues to grow in the future.
Yeah, absolutely. Now, there's been an audience question, which I have to admit I was also thinking myself. So the question is, the conversation so far has mainly revolved around the GLP-1 product features, clinical medical differentiation. Christine, you highlighted that is not going anywhere, but we also have highlighted, and we've seen it in the poll results, that access and price remain such a hurdle. And of course, generic players are already prevalent in some geographies. I think someone was talking about how in India, which of course always has more generic competition, but I don't think we can ignore the fact that the window isn't as short as long as we think it is, certainly on the semaglutide side of things. So how do the panelists see the shift from a product-centric to a platform strategy? Product plus service, patient adherence, telehealth, companion apps. These are words that we haven't talked about yet. The go-to-market model will therefore perhaps shift from in-house to a partnering model, as the questioner says. So talk to me a bit more about the system, and do we see a move in investment strategy into how the system is changing? Do you even believe that the best way of succeeding in this market is primarily clinical based going forward compared to the system?
I would say no. I mean, yeah, the clinical is the foundation. you have to deliver on the clinical benefits to be successful. But yeah, to your point, there is a lot that needs to be wrapped around it from a platform standpoint to get uptake and to get adoption. And so I think in the US, there was a glimpse of kind of generic market dynamics for a period of time with compounding when supply was an issue, and there was a big focus for a lot of compounders and some of the telehealth companies to take advantage of that opportunity. And I think it's definitely dialed back a lot as manufacturers have gotten more litigious, but I think that still has embedded a lot of the telehealth options for patients to pursue these treatments through different channels. So I think for Lilly with their Foundeo launch, that was telehealth was very central to that, and I think their initial uptake has been maybe a third through telehealth platforms so far as they're looking to get more access. But I think that all those components are important in addition to kind of the clinical solution, thinking through how are patients going to get access to treatment, how are we going to distribute, how are we going to have alternative channels. Obviously, Lilly and Novo both set up their own self-pay options with pharmacy distribution, and I would expect that to be the case for others in the future, and working with telehealth partners to make options available, and even having other wraparound services that the telehealth providers are able to offer as revenue streams for basically coaching on top of the nutritional coaching and other types of care services that aren't just the drug itself. So I think those are all important, and especially think there's more to just the clinical profile. And when you look at adherence dynamics today in the space, where I think the persistence rate for at least for Wegovy is around 32% at 12 months. So a lot of patients are really dropping off, and there's definitely a need to try to figure out how to fix that part of the equation from a patient journey standpoint.
So you gave two numbers, very similar numbers. You said 30% through prescribed initially through telehealth services, and telehealth, for want of a better word, has become unsexy since the pandemic. So I'm really interested in whether or not you think that it's the stigma factor or what else might be driving that. So that was the first 30%. And then, of course, you said about 32% adherence after 12 months, which if that was a life-saving medicine, we'd all be panicking right now. So 32% is not high. And I'm interested in, again, whether it's that long tail that you think that entrants can really benefit from. Is that adherence number the place to work on? Is that a number that can be raised significantly with minimal intervention?
Yeah, I mean, I think there may be some element, and some of it is definitely driven by the access and cost issues for patients. But I think there's also a little bit of an expectation, both for patients and providers, that patients may not be on the drug for life, even though I think there's an argument to be made that obesity is a chronic condition, and even once you finish the weight loss phase, you should still be treated in some capacity to prevent regaining weight.
And everyone knows that, right? That's what I find confusing. Everybody knows that the weight comes back on, and it comes back on with a vengeance, and yet that is a low adherence rate, I would argue.
Yeah. And I think some of that can be different patient populations that are using it, for a short-term solution, or that patients may be, discontinuing to see how they do, switch to another treatment. I think you've seen with some of the oral options where manufacturers are trying to, create data, clinical data, to show that orals could be a good option for long-term maintenance for patients. So if they start with an injectable treatment, have significant weight loss, reach more of a plateau, and they want to maybe switch to a lower cost option to maintain that, the orals could be a solution, for that. And so I think there's different ways of potentially addressing that adherence issue. But I think it's a little shocking to see just how short that window can be for a lot of patients in terms of staying on the drug.
Yes, indeed. Well, many things I could say in response to that. Christine, I'd love to hear your thoughts on this. adherence and the telehealth thing, if you want to talk about that. I'm not expecting you to focus on that, but certainly where you think that we could move the needle.
Of course. With respect to differentiation, Sean brought up really good points. I think, Paul, to your question, is it addressable? I think we would have to understand what's the core factor driving that lack of adherence. It's a little high. Could be any of the factors that Sean mentioned. But I think it's possible to potentially move the needle once you kind of understand what the driving factor is. I wouldn't be surprised if a lot of that, again, is access and or tolerability, for example. With respect to telehealth, to me, the clinical piece and the system piece should be working in tandem. I think if someone can build that framework from a telehealth perspective and bring that back to life to improve access, could be a game changer for these patients, with demand being so high. And it's just a question of, can patients afford it and get access to it? And is their drug available, right? I've heard of some manufacturing issues as well, just to meet demand. To me, that is a positive for patients, for sure.
Sure. Okay. I'm going to share the results of the latest poll. Thank you to everyone who answered those. I think there's some interesting results here, particularly in the 50%, the highest number we've seen so far, gets the top score for which route to market feels most important or relevant to get on top of now, being that direct patient activation alongside HCP engagement. That is the new ground that everyone has to be aware of. I guess I'm really interested. I haven't really asked you guys, Sean and Christine. I know you have experience across multiple therapies, and something you haven't addressed yet is how much of a knock-on effect do you think those DTP platforms, of course we are seeing them outside of obesity already, but how much of a factor do you, and long-term sort of permanent factor, do you think that will play in other therapy areas outside of obesity? I'd be really interested to hear your opinion on, whether that is the battleground or the battleground skill to be on top of for everyone at the moment. And then the second question here was, what's the biggest barrier to moving beyond traditional? I did give compliance or regulatory MLR a fair hearing on this, and it was the joint top spot in this poll with 23%. So that was interesting, but lack of proven models or benchmarks in joint first place there. So guys, talk to me about the beyond the obesity effect, if you can.
Yeah, to your question about will telehealth permeate other areas, I mean, I think yes, but not everywhere. I think it's especially relevant for more stigmatized areas, and I think you see that with Hims and Hers and Roe, and where they're focusing with categories like mental health, erectile dysfunction, in addition to weight loss. And I think also where convenience plays a factor, where patients want something that's simple and easy, and being able to not leave your house and get access to treatment, I think is important. But I don't think you're going to see that with telehealth being a mainstay, or direct to consumer plays for heart failure or other categories where there's more in clinic requirements for diagnosis, testing, and more holistic evaluations. So I think it has definitely accelerated that trend. Obviously, COVID was the big accelerator, but GLP-1s are helping to embed some of those platforms as well.
Sean, could I press you for a prediction? If you had to put your money on something of notable change 5 years from now, being different from what it is today, when it comes to non-obesity areas, what would you say would have changed, perhaps influenced by obesity, that you would be willing to bet some money on?
Yeah, I mean, we get a lot of questions from clients around for non-obesity related categories, or where there's obesity is maybe a factor, like how are GLP-1s going to impact our market or our industry? And so I think it's in spaces like ortho with joint replacements, or medical aesthetics, in terms of both impacting share of wallet for spending on medical aesthetics treatments, but then also maybe generating a new demand or new interest for patients post weight loss, or even things like hernia surgery, where obesity can be a driver of a need for that, or insulin pumps is like a downstream impact for type 2 diabetes patients that may be less likely to go on pump therapy or reach insulin treatment. And so there's a lot of, I think, long-term downstream consequences that for a lot of spaces could come to fruition. I know there in the news you see some of these headlines about pressure on like Pepsi's stock price because of GLP-1s and the impact that's likely to have on junk food or snacking, which I think some of that's a little bit overhyped. But I think long term they're definitely going to be, I don't know if 5 years is the right time horizon, but there will definitely be changes as these drugs take hold and we're able to kind of bend the curve for obesity. And I think in the U.S. The last couple of years has been the first time that the obesity rate has started to kind of flatten out and even decline, and which I think is promising. But there's still a lot more runway to go there, and I think that will definitely change a lot of other markets and industries.
Right. So my takeaway from my where will you place your bets question is short Pepsi, based on what you just said there, Sean. So no, it's all right.
I mean,
You're not giving real investment advice. I realize.
Yeah, maybe just based on the scare factor there, but I think that they're trying to make the argument that there's upside with health foods and being able to charge more premium or change their mix, and yeah, it's just changing in a lot of places. So
I'm sure Pepsi is adjusting accordingly. Christine, I would love to hear your thoughts on the beyond obesity questions.
Sure. So, as I mentioned before, branching out into other cardiometabolic related areas is an obvious play, and whether that's going to be successful or not, TBD. An area that's really interesting to me, and I hear a lot of people mention they feel benefit on GLP-1s, is mood and anxiety, for example. This is obviously just patient reported. There's nothing approved, but I think it's fascinating that we have drugs on the market that potentially have can extend into therapeutic indications like that. Unrelated clinically, something we don't really talk about often, but I think is really interesting from a demand standpoint, is oftentimes people make decisions for their employer based on whether their GLP-1 will be covered or not. So from a business standpoint, I find that piece fascinating. We tend to focus on the clinical aspects, but from a work productivity standpoint, for example, people often will make choices based on the coverage of their drugs at their employer. So that's something to consider as well.
Absolutely. Now, Christine, I've been pushing most of the questions so far today on the beyond the clinical areas, but of course you are someone who understands clinical development, endpoint development, and of course all of the access questions that go alongside of that. So I do want to perhaps relieve you by asking you a question about those areas. And I guess I'm keen to know from an obesity angle what you think the clinical superiority data that will make a difference is. And of course, you could, of course, again, give me a non-obesity answer. You could say it's, of course, the efficacy in other disease areas that's going to make the difference. But I'm also super keen on, just from a clinical point of view, where you think the difference is going to be made in the obesity market going forward.
Sure. And this is theoretical, right? With some conjecture for you. And it goes back to what Sean mentioned earlier, which I think is a really good point towards the beginning. In terms of differentiation, a big topic of conversation in this class is it's not just the percent weight loss, it's the body composition changes. There's data to support outside of obesity, right? That muscle mass can dictate risk of particular outcomes, mortality, and other things. So to me, if I put my clinical hat on, I think that is a key point of differentiation, because if a drug can show that it can improve not only weight loss, but actually can improve body composition in a way where that patient can achieve weight loss and not put that patient at additional risk for other outcomes, to me is clinically, I think, a big deal. So within obesity, I think that to me is key. And that's something I think about a lot in this disease. And of course, if you look at the clinical development pipeline, there are a couple options in the pipeline trying to address that. Whether they'll be successful or not, who knows? That may come down to differences in mechanism of action as well. But these are all question marks that we're waiting to see if we in industry can answer.
Sure. And of course, I think it would be very tough for me to ask you to predict on a clinical basis what's going to be successful. But is there anything that gets you particularly excited? Is there anything that you've learned about that you found notable in any area when it comes to the efficacy and clinical performance of anything that's on the horizon that intrigues you particularly?
If you look at the data, particularly the recent data from Eli Lilly, the magnitude, the percent of weight loss, it's striking. And so as these options continue to come potentially to market, what we're able to achieve therapeutically in weight loss is quite remarkable. What excites me about this space is how it's changing how, essentially what we've been talking about today, how it changes the framework for how we market these drugs, the direct-to-consumer pharmacies from industry, the high patient demand. In essence, we are not trying to create demand, we're trying to meet it. And so, of course, me with my medical affairs hat, I think about the clinical data, but we all have to work together in tandem, right, from a medical, clinical, commercial standpoint to bring these drugs to fruition and the strategy to fruition.
Excellent, indeed. Sean, I'm assuming you don't want me to ask you any clinical questions, so I'm going to go to the poll results. Feel free to comment if you want. Anything? I assume not. Okay, I didn't hear anything from you, so I'm assuming not. So I'm going to.
You're asking about on the clinical side?
Oh, yes, exactly. Sorry, my connection may not be perfect. Yes.
No,
Sean.
I mean, I just completely agree, Christine, with your point. I think that's the composition benefit is, I think, huge opportunity and something that I'm excited about, because I think patients are not just looking for, at the end of the day, like I think a lot of people are gravitating towards a single percentage weight loss number, especially, the street, when it looks at some of the results of these clinical trials, it's highly reactive to comparing some of those endpoints from a weight loss magnitude standpoint, and also looking at some of the tolerability metrics. But there's so much more to like what patients actually clinically need for the best outcomes, and that I think body composition is the when people are seeking to lose weight, they're seeking to lose fat in a majority of cases, and not seeking to lose muscle. So I think even things like, in the future, if there could be some differentiation around visceral fat reduction, in addition to body compensation generally, I think that could be really interesting as well.
And I'll add that will be a lift in terms of education, right? Because most patients are just looking at that percent weight reduction, and I would say probably don't understand the differences in body composition. So, thinking forward, if that's going to be the play, that's an educational initiative in and of itself for patients, I think for providers probably as well.
Yeah.
Why do you think that's I mean, it doesn't seem to, and maybe I'm just ignorant of what people are like, but that doesn't seem to be a difficult concept for people to understand. It seems to be something that people would clearly experience once they're on the medicine, is that they have the muscle loss. I certainly know that people that I know that take these medicines have been very good at doing weight training and other forms of protein based intake that are designed to stem muscle loss. Why is that, do you think, such an educational hurdle still, Christine?
Well, is your sample my scientific response is that a representative sample one, right?
Probably not.
Regardless, if that is going to be your point of differentiation as a company, it behooves any company to educate on that as the differentiation story, to make a compelling story, to choose X product over another. And in addition to that, if that can improve outcomes for patients in the long run, in addition to helping them lose weight in the short term, I think that's a win-win for everyone.
Yeah.
Well, Maria in the comments is telling me that most people do not lift weights or eat properly, but it's about
so I've been validated. Thank you.
They
yes.
should be doing. So, yeah. It's not whether they're doing so.
There are it's always surprising, like the basics that not everyone knows are being enacted in clinical practice. Like I think we had seen data in some of our research just around stigma as a consideration that a lot of providers aren't even having a weight discussion with obese patients in their annual visit. And it's like less than half of patients are actually having that discussion around weight management in that PCP visit, or even accurately coding, obesity. Or I think there's even concerns that there are a lot of prescribers or HCPs or PCPs that don't believe that medication is required to treat obesity, that there should be, lifestyle modifications are the go-to, at least initially. And so I think there's a lot of things that still need to be addressed from like a basic standpoint, and getting to body composition is kind of one evolution down that path. But I think even using BMI as a metric is a little bit crude today, because you can technically have a high BMI and be extremely healthy and just have a lot of muscle. There's things like that that I think are future evolutions and need more education, both from a provider standpoint, and even for patients that are making some of these choices around which option might be best for them.
Sure. Okay, guys, we've only got 3 minutes left. You can see that the results of that latest poll, interestingly, only 13% of people said that the quality of weight loss was the thing that matters most, and 30% of people just saying stronger outcomes in related therapies beyond weight loss. So that I thought was quite interesting, some change there. And I'm just going to do one final poll question for you all to answer in the background whilst I ask you a final question, Sean and Christine. And my final question is a simple one, not necessarily simple to answer, but simple in concept, which is you are now CEO of Lilly. Congratulations, David has been ousted. You obviously have built a huge market following and reputation based on your results in this therapy area. What do you do? What do you do now? What's your magic wand going to wave and do and say for you to maintain your market leading position in this area? And not an easy question, I realize, but you've only got time to say 1 or 2 sentences. So hopefully that means you can just focus on 1 or 2 things that you would perhaps consider in that position.
Yeah, I would happy to jump in, but I mean they're in a very good position now. So I think there's a certain element of kind of continuing to execute on the advantage that they have, with the advantage of, I think it's fair to say Zepbound has a pretty good clinical data advantage, and their pipeline is also strong. I think there's a new battleground this year in orals where Wegovy pill launched ahead of Foundayo, and so I think that's like an important part for Lilly to get right. And then I think they're also banking a lot of their future opportunity on Reta in the pipeline, to be kind of that next generation asset. But I think for them, just given their market position and the amount of revenue success they've had today, I think it's kind of a building the moat strategy. So it's continuing to invest in additional data, more new indications, kind of creating a full package that differentiates you from any potential new entrant, and can help maintain your leading share, at least in the injectable space.
Christine.
Sure. As I come down from the
less than a
cloud,
minute.
thinking about what that might feel like, and we're at time, I would say indication expansion. I think that's going to be really, really key here. I agree, Eli Lilly's in a great position, but indication expansion will be important.
Okay, guys, thank you so much for your time. We have run out of space. That wasn't supposed to be a metaphor, but thank you so much for your insights, thoughts, and wisdom today. It's hugely appreciated that you are willing to stand up and think how we can advance our industry and make sure that not only is the health of our industry maintained, but also the health of our patients going forward. So thank you ever so much. Really appreciate you in the audience as well for obviously all of your time, and anyone that's contributed with questions. Extra gold star to you. If you've got any ideas or suggestions for what you'd like to hear going on next, then I would really appreciate it. I want to say a massive thank you to obviously Christine for stepping in and being part of this, but also to Sean's team, BGBx, who have actually been a partner of ours on making sure that today's webinar was a success. So huge thanks. Wonderful team, great people to work with. Very much recommended if you're not familiar with the company to go and check them out and learn a bit more about how they can support in these key areas. Apart from that, I obviously want to say a huge thank you for joining me while I'm on vacation here. I'm obviously going to go back now and enjoy a large glass of sangria. I very much hope that you're going to do something similar, even if it is still morning your time. I know that Christine is still the crack of dawn for her, so maybe wait a couple of hours. But Christine, thank you so much for all of your attention today. Okay, we're a couple of minutes over, so I will let you go. Don't want you to be late. Thanks again, everybody, and we will see you again very soon.